Labor and delivery. As we talk about what to do during labor and delivery, there are several things that are really important. First of all, you need to note all your times. Keep an eye on that clock. Jot down a time here and there as you go so you can keep track. In a labor and delivery situation, things can move along pretty fast. So, one place to really keep accurate track of your time is on your fetal monitor strip. If you do a vaginal prep, document it on the fetal monitoring strip. If you apply oxygen to the patient, put it on your fetal monitoring strip. It's a very handy piece of paper. It's already got the time on it, and it will allow you to sit down when you have the opportunity to document and document your times appropriately. Normals for contractions, once again, are going to be about 2 to 3 minutes apart, and contractions will last about 60 to 90 seconds long. As mom gets closer and closer to the time of delivery, she's going to have an increased amount of bloody show. So if you're starting to see a heavier bloody show and it's mucousy, then chances are she is really starting to progress. Now, if it's frank blood and there is a difference, then you may want to be concerned that she may have an abruption or she may have a placenta previa that may be causing her to bleed. Understand that membranes can break at any time during labor and delivery. Usually the physician will rupture the membranes if they do not rupture on their own when she is showing steady progression, and once the baby is well seated in the pelvic canal. And normal fetal heart rates are going to be 110 to 160 beats per minute. Interventions. You've got to stay calm. Getting excited, getting anxious, getting high strung is not going to help your patient at all. The better you can stay calm, the better the situation will play out. As mom comes in, you need to obtain as much prenatal history as possible, which would include your estimated date of confinement or your EDC. The contractions, when did they start? How far apart are they? How long are they lasting? And how strong are they? And don't forget to use palpation to determine the actual strength. Is she having any bloody show? And if so, how heavy is it? Where is her pain located at? Contractions normally will start in the back and move around to the front as the contraction intensifies, or it may start in the front and move to the back. It usually encompasses the entire belly by the time the contraction is full blown. Has she had any problems with the pregnancy? Who is her doctor? And what is her gravida para? And have her membranes ruptured? And if they have ruptured, always, always, always remember TACO: time, amount, color, and odor. Do your best to help mom stay in control. Once again, the calmer you are, the calmer she's going to be, and the better outcome you're going to have ultimately. If she is not breathing in a good normal pattern, then help her to reestablish appropriate patterns. Reassure her that you are capable of delivering the baby if the physician does not arrive, if that should come up. Direct the support person to help mom as needed. A lot of times these coaches are kind of shell-shocked, and maybe they have been through a childbirth class, but a lot of times it gets down to it, they tend to forget what they need to be doing. And sometimes a little gentle prompting will get them back on track. Make sure mom is positioned for comfort. She does not have to be in a lithotomy position. She doesn't have to be uh, in any particular position whatsoever, unless the doctor specifically requests it. She can be in whatever position is going to be the most comfortable for her. And recommend comfort measures as necessary. That's why we go through the childbirth class, so you're familiar with different comfort measures. Again, mom and coach don't always remember these measures that can be used during the labor process, and it's very beneficial for the nurse to be aware of what can be done. Gather the appropriate equipment as necessary. You'll need the infant warmer and resuscitation equipment for the newborn in case it's necessary. Of course, you'll need a cord clamp and or hemostats, scissors to cut the cord, a bowl to place the placenta in, gloves, preferably sterile, a bulb syringe to suction out the infant's nose and mouth, clean blankets and towels, because remember, one of the first things we're going to do once that baby is born is get it dried off. You'll need vaginal pads, cold packs, and a delivery pack and or table. Continue to monitor mom and the baby per guidelines. If at all possible, maternal vital signs are great, but if she is in transition or you get vital signs when she's in the middle of a contraction, the vital signs may not be very accurate. Monitor fetal heart tones. Monitor the contraction frequency, duration, and strength. And remember that the A1 suggestions as to the frequency of monitoring is based on the individual maternal and fetal situation, as is the method of monitoring. But the recommended guidelines from A1 are during the active first stage, you should monitor mom and baby every 15 to 30 minutes. And during the active second stage, monitor mom and baby every 5 to 15 minutes. Of course, this is with a non-complicated labor and a low-risk pregnancy. And if at all possible, you really should have a saline lock and or intravenous fluids going. And usually the fluids that we would run would be lactated ringers, infusing at a rate of about 100 to 125 mLs per hour. Sometimes a mom will come in the door and she just has this look about her, or you've been monitoring her labor and things haven't been moving very fast, but all of a sudden something is different. There are some very significant signs that you can watch for that can very, very accurately predict impending delivery without doing a vaginal check. First of all, you look at mom's face. She may have this wild and or a glazed look in her eyes. It's kind of the deer in the headlight look. Mom is very focused inwardly and she doesn't interact with others. She may have some nausea and or vomiting. She may start tremoring. Tremoring would look like chilling with a fever, but she's not running a temperature. She may be grunting with the contractions, but she tells you she's not pushing. If she is grunting like that with the contraction, she is definitely pushing. Or she just flat out states, I've got to push, or the baby's coming. I have this fetal monitoring strip on the slide just to help demonstrate what pushing looks like from the contraction standpoint. If you look at the contractions on the bottom portion of the strip, you can see that they're kind of squared off. Then they'll have a dip. That's where mom is taking a breath. And as she begins to push again, then the graph goes back up to, in this slide, to approximately 80. So you see that pattern on the monitor, you know mom is actually pushing. And if you look at the baby's portion of it, a lot of times when mom is pushing, you may see accelerations in the fetal heart rate, and you may also see the variable decelerations and or early decelerations when there is pressure being put on the baby's head or possibly the cord is being compressed. So it's getting close to time for delivery. First of all, you want to notify the physician per the physician's instructions. Generally, there is some standards, but it is individualized per labor. For the multiparas, usually it's 8 centimeters, and for the primeps, it's usually 10 centimeters. So when these women reach that stage of dilatation, that's when you would normally call the physician. But at the same time, I have a personal experience of a woman in labor. She was a multipara. She was complaining very loudly throughout her labor. She just really was not dealing well with it. I checked her and she was 5 centimeters. I had just come on my shift. As I walked out of the hallway, after determining that the patient didn't require anything, the aide came up to me wanting to know what was going on because the mother was so loud you could hear her out in the hallway. And I told her that, you know, she's just not dealing well with the contraction. She's only dilated to a 5. She still has a ways to go, you know, and walked to the desk, sat down, picked up my pen, took a breath. I was getting ready to document my assessment, and the patient's husband came out to the desk and said she's got to push. I took a deep breath because, you know, I had just checked her not even 5 minutes before. But I said, okay, laid my pen down and walked back to the patient's room. She's still very obviously not dealing well with the contractions, but she's holding her hand down at her crotch. I pulled my glove on and walked around to her side and told her that as soon as the contraction was over, let me know and I would check her again. And as that contraction was completed and she moved her hand, I lifted her gown to check her. The baby is crowning. So she had gone from a 5 to crowning in approximately 5 minutes. But the point of my story is when the doctor came in, I actually delivered that baby, and the doctor came in, he was very upset. He said I instructed the nurse to notify me when she reached 4 centimeters because she has a history of going very quickly once she hits 5. It's like, you know, I'm really sorry, but that was not passed on in report. So basically, the physicians a lot of times will know these patients and they will know their history, and they know if they need to be there when they're dilated to a lesser degree. So always do what your physician requests, but otherwise 8 for multiparas and 10 for primeps. And there may become a situation where you need to have a second person make that phone call rather than you yourself. Once mother is complete, then you need to be sure you stay with her. Do not leave her. When the client is prepped and positioned, In other words, the bed is broken apart and her legs are up on the footrests. Stay at the client's perineum until the physician arrives. Position mom. Break down that birthing bed, remove the bottom portion of it, and we will demonstrate this to you when we do our simulation. The typical position for mom to be in is that C position, but it's not the only position she can be in. So again, whatever position is going to be most comfortable for her. Position the support person on the side that does not have all of the equipment, so on the opposite side of the fetal monitor and the IV pole, etc. Cleanse mom's perineum, and you'll do that per facility recommendations. Each facility is slightly different. It is a sterile procedure. Usually the cleansing solution will be a betadine scrub or Hibiclens or Sure-Cleanse. You'll go down the center of the perineum 2 to 3 times. You'll go on each side and out onto the thighs, and then rinse it with sterile water. Following that, the physician's there. You're going to assist with the delivery process. Don't forget to continue encouraging the support person to participate in supporting mom, and fill in as needed. Provide physician assistance as required, and continue to monitor the vital signs of mom and the fetal heart rate, realizing though that if mom is pushing or she's having a contraction, that the blood pressure and heart rate are probably not going to be accurate. And also understand that as the fetus tends to move down into the birth canal, you may have to move the ultrasound to be able to continue to obtain the fetal heart rate. And then following delivery of the newborn, you will assume newborn care and continue to provide physician assistance as required. If the physician doesn't make it, and although it's not something that we encourage, these situations do happen and the nurse does catch the baby, you need to support the baby's head on the perineum, but you never prevent the head from delivering. If the membranes have not ruptured at delivery, you will rupture the membranes by tearing the bag of waters at the nape of the fetal neck if necessary. Usually they have ruptured at this point, but if it's a really rapid labor, there are times when it hasn't. Always remember that you suction the baby's mouth and then the nose, and try and do it on the perineum if at all possible. Sometimes the mother is just so involved in pushing, though, that you don't have that opportunity. So suction the baby's mouth and then the nose if possible. If it's not possible, you do it immediately following delivery. Check for a nuchal cord around the baby's neck, and if there is a nuchal cord, you will gently slip the cord over the baby's head. If the cord is too tight to slip over the baby's head, then you will clamp the cord in 2 places and cut it prior to delivering the rest of the fetal body. At this point, you will instruct mom to go ahead and push, and you will deliver the shoulders. With both hands, you gently exert a downward pressure to deliver the upper shoulder. After that shoulder is delivered, you gently exert an upward pressure to deliver the posterior shoulder. If you've not had to clamp and cut the cord at this point, then after placing the baby on mom's abdomen, you will cut the cord in 2 places, or clamp the cord in 2 places and cut it between the clamps. If the support person is available and they are wanting to do so, allow the support person to cut the cord. Again, the baby will go onto mom's abdomen, and you toss a dry towel or blanket over the top of the baby, because remember, they will lose heat very, very quickly. They are wet and we want to dry all of the fluid off of the baby as soon as possible. Once you have dried the baby, remove the wet linens and cover the baby with something that is now dry. If, excuse me, if you have called the physician but mom is just adamantly stating, I've got to push, discourage her from pushing. If you've ever been in a labor process and you've had that uncontrollable urge to push, having someone tell you not to push is basically torture. It is okay to allow mom to push. Usually it's going to take more than one push to push the baby out, and normally the physician will arrive prior to that. Now, I never actually encourage mom to push unless she is telling me that she's got to push. In that case, again, I don't discourage her. I tell her, go ahead, it's all right. So after delivery of the baby, then we watch for signs of placental separation. Again, the cord is going to get longer on the perineum. You'll start seeing a heavier blood flow. Mom might complain of some uterine cramping, but she may be so involved in the baby that she doesn't even notice. If you're able to, and the doctor is not there, unclamp the cord from the mom's side and drain a little bit of cord blood into the tube that's usually provided. Then reclamp the cord. If you don't, it's not that big of a deal because you can always go back and take a syringe. And if you look at the picture of this placenta on the slide, then you can see all of those large blood vessels running through the placenta. You can actually withdraw blood from those blood vessels. Sometimes it's not, excuse me, you have to do multiple sticks to be able to withdraw enough blood, but it can be done. Never pull on the placental cord, the umbilical cord. Once the placenta delivers, it needs to be placed in a container, usually a bowl, in order to examine it a little bit later to make sure that it has come out in one piece. Following delivery of the placenta, mom gets a dose of Pitocin or Methergin, depending on the physician. Usually, if she has IV fluids running, then you add 1 vial or 10 units of Pitocin to the bag and infuse it at about 125 mLs per hour. You can titrate that fluid rate if the lochia is heavy. If there's less than 500 mLs in the IV bag, then you can hang a new IV bag, or you can just inject the Pitocin, the 10 units, intramuscularly. Following delivery, we will usually infuse a Pitocin drip for 1 to 2 hours, depending on the vital signs and the lochia. Postpartum care. You're going to monitor the vital signs, and you pretty much follow the surgical postoperative vital sign routine. We monitor them every 15 minutes for an hour, every 30 minutes for an hour, then every hour times 1, every 2 hours times 1, and then we back off to every 4 hours. With the monitoring of the vital signs, you should also be massaging the fundus and observing the lochia. You can also do it PRN. Remember, if mom immediately postpartum or even a day or two postpartum begins to have a heavier lochia, you want to make sure that that fundus is firm. So the first thing you're going to do is massage the fundus. Following delivery, then you're going to delivery of the placenta, you'll cleanse the perineum using sterile water. You'll place the vaginal pads and place ice packs, especially if she had to push for an extended period of time or she had any tears, episiotomy, has much edema. But do not ever place the ice packs directly against the skin. Now, depending on where you work, the epidural catheter will need to be discontinued, and you discontinue it per facility protocol. I worked at Pratt Regional Medical Center, and in the obstetrical department, we were trained to remove the epidural catheters ourselves. The anesthetists were very comfortable with us doing that. It's not done very many places. The anesthetists were really glad when I was working in intensive care and we had an epidural cath that needed to come out, because they could just have me do it versus having to interrupt the surgery or try and come between surgical cases to remove a catheter. Anyway, in order to discontinue an epidural catheter, you'll either set the client up or you'll roll them to one side. You'll use a steady pressure to pull the catheter out. Sometimes it kind of gets caught between the vertebrae, so you may have to have mom arch her back, sit straight up, or just reposition to help facilitate removal. And as with a Foley catheter or an intravenous catheter, you always want to inspect the catheter for integrity. Make sure that it comes out in one piece. And never force removal. And then a Band-Aid is usually placed over the insertion site. Then you want to position mom in a position of comfort and encourage breastfeeding as indicated. If she is planning on breastfeeding, we like to get that baby latched on usually within 30 to 60 minutes following delivery. It helps promote success for breastfeeding. And sometimes, especially with the new moms, they need some assistance in getting that baby positioned appropriately and getting themselves positioned appropriately. And then any medications that mom may be needing, especially if they're breastfeeding. This does stimulate the release of oxytocin, the natural oxytocin, and they may be feeling quite strong after pains and may be requiring something for pain. Newborn care. Again, the very first thing we want to do following placing the infant on mom's abdomen is dry and stimulate the newborn. We stimulate the baby by rubbing the back and or flicking the feet. And as soon as possible, remove those wet towels. Usually we just toss them on the floor in a pile. You're going to obtain vital signs at 1 minute, 5 minutes, 10 minutes, and 15 minutes following delivery. Then every 15 minutes times 3, which would comprise the first hour. Every 30 minutes times 2. Every hour times 1. Every 2 hours times 1. And then every 4 hours. Obtain your APGAR scoring per facility protocol. So maybe it's every 1 minute and 5 minutes, but maybe it's every 1, 5, and 10. Maintain temperature control. Your hat is going to be very, very important. And blankets. But remember that mom is the best incubator. And also realize, especially with the breastfeeding babies, that breast tissue changes temperature up to 1 to 2 degrees to help keep the baby warm. Again, you're going to assist mom with positioning and latch on if she's breastfeeding. Obtain prints, footprints for the baby, and there is an identification sheet that will actually be sent to the state. The birth certificate, there's usually a facility birth certificate that they provide as a keepsake. It's not the legal one though. There may be a crib card, and mom or dad may have a baby book that they would like to have prints placed in. For mother, you'll get fingerprints and thumbprints. You'll get an index fingerprint on the identification sheet and the crib card, and thumbprints on the certificate, birth certificate. And remember, prints should be obtained prior to separating the mother and the baby. You will place identification bracelets, again, prior to separating mom and baby. The procedure that I'm accustomed to using is that you will have a bracelet for baby's wrist and baby's ankle, and they were to be placed on opposite sides. So if you placed a bracelet on a left wrist, the ankle would be the right ankle. And frequently there is an alarm on the ankle bracelet. You'll give the vitamin K injection in either thigh. You'll place ophthalmic ointment, and frequently it will require 2 people because right after delivery those little eyelids are pretty slick, and you've got your gloves on, and it's difficult to pry those babies' eyes open enough to be able to apply the ointment. Perform the assessments as you have the opportunity. You'll be doing the newborn assessment, and you'll be doing a gestational age assessment. You'll also obtain measurements as you have the opportunity. You will measure the circumference of the head, chest, and abdomen. You'll measure the distance between the shoulders and measure the length. You will also obtain the weight in pounds and grams. Your measurements, your length measurements are all going to be in centimeters and inches. Then when mom is ready to release the baby for a while, you're going to bathe the newborn. A lot of support people like to videotape that first bath. So if that's something that they're wanting to do, we always try to accommodate their wishes. You know, this is a major moment in their lives, and we do what we can to make it as special as possible. Remember, there's no soap on the infant's face, and it'll require the cotton-tipped swabs in order to sufficiently cleanse the pinna of the ear. And obtain any lab work per physician order, and the cord blood will go to the lab in order to help determine the newborn's blood type. So what happens if the baby doesn't respond the way baby is supposed to respond? You need to know resuscitation. First of all, keep the baby warm, and that's going to be one of the most important things you can do. Sometimes warmth is the key to response. Start thinking, did mom receive any medications? Did she have any analgesia or anesthesia, etc.? And sometimes, even if you don't think you think it's been way too long for the baby to have any effects from medications mom has received, sometimes just giving a dose of Narcan intramuscularly will make a world of difference. And these babies, if they do respond to Narcan, usually will respond within 1 to 2 minutes with an IM injection. It's actually pretty amazing. If they do not pink up quickly, be sure you provide tactile stimulation. Remember, we like to hear these babies cry. It helps them make that conversion from fetal circulation to newborn circulation. And as I'm talking about pinking up, remember it's the central pink that we're looking for. It's okay if the hands and the feet are blue. That's, again, is called acrocyanosis. But we want the trunk, the chest, and the abdomen to be nice and pink. If it's not pinking up, then tactile stimulation. Again, if that central color is not pink, you may also need to provide some blow-by oxygen. Blow-by can be provided by a mask that's sitting lightly on the newborn's face, or with the hand cupped around the oxygen tubing and held over the newborn's mouth and nose. If the fetal pulse, the newborn pulse, is less than 100 and or the baby is not breathing, it's necessary to provide positive pressure ventilations. In other words, you are going to be breathing for the baby. If the pulse is less than 60, then we provide chest compressions in a newborn.